that being said, I'm going to read through Dr. Murphy's bio, and then I will leave it in your very capable hands. So, Dr. Pamela Murphy, MD, is a pediatrician with a long history of care of individuals with special healthcare needs. Since 2007, she has been the lead physician at the Myelomeningocele Planning Clinic at the Children's Rehabilitative Services in Phoenix, and since 2016 has been the principal investigator for the Phoenix Clinic's participation in the National Spina Bifida Patient Registry. She is a lead author of a novel case series on environmental buttocks burns in children and teens with spina bifida in the social work published in the Pediatric Journal of Rehabilitative Medicine in 2019. Some of the main goals of the clinic are social continence and independent care, which she's quite passionate about. And Dr. Murphy, I do want to let you know that we've already received several questions in the chat about the bladder and bowel management. And so I'm sure that you'll be answering many of those questions as you go on. So I'll let you just kind of get started, and I'll bring up relevant questions as you go forth. But with that, welcome. And we're excited to hear what you have to say.
Thank you very much. I appreciate the opportunity to be here. Thanks to Sherry Reynolds, our executive director of our Arizona chapter. I'm in Phoenix, and I could talk about spina bifida for a few hours, so I will have to be careful about how long I speak. I'm going to go ahead and share my screen. Sorry, I'm slow at this tech stuff, and we're gonna do the slideshow function here. And not sure where the rest of that slide went, but I'm gonna go ahead and move on to the next one. Oh, I see what's happening. So I did not realize I had done this to this slide. So we're going to talk about bladder and bowel health and spina bifida today. And yeah, please stop me and ask questions as we go. And please let me know if there's any problems with the audio, or if I'm too loud or too soft. Objectives, I'm so used to making sure I have objectives on a talk. So we're going to learn about bladder and bowel health and spina bifida. We're going to discuss the importance of protection of the kidney and discuss the importance of social continence, which I'm very passionate about. And then we'll review the many options for management of bowel continence, especially. So these are my two favorite icons. I am a pediatrician. I know there's adults on the education program today. I do note that I usually talk to kids, so I'm talking about pee and poop. And yesterday I went into the adult clinic because they needed someone to come in, and I saw some young adults, and I had to change my words that I use, talking about tummy and needing to adjust to address them as adults. So I apologize if I come across sounding like a pediatrician. I'd like to first start, I know most of you know this, spina bifida has open and closed defects. And so on the far right, we have myelomeningocele, and this is where the nerves at the end of the spine are kind of caught up in this ball on the outside, and people with myelomeningocele are either repaired in utero or in the first day of life because it needs to be closed. The meningocele is more a closed defect as opposed to an open defect, and those people may have surgery at a later time, and you will see the skin covering when they are young before it is repaired. So sometimes when I'm referring to bladder and bowel issues, I will be referring to myelomeningocele or the non-myelomeningocele. But I think this group probably knows this well. What I find interesting is that when we talk about the bladder, we usually think of it as just a balloon and it holds the urine and then we let the urine out. It is way more complex than that, and thank goodness we have urologists who specialize in this and take very good care of all of our spina bifida patients, family members, and individuals. So what I'm showing here on the left is this is the spine, and most of you know this. We're we're talking about the thigh, the thoracic level 11, 12, and then lumbar 1, 2, 3, 4, 5, and then we have the sacral. And most of you probably know this based on the motor function that your physical therapist has talked to you about. What level does your child or do you as an individual function at from a motor perspective? Well, this is to just show you the complexity of the nerves that control the bladder. So you can see down here the parasympathetic and sympathetic. Those are the part of the system that is non-voluntary. We think of the sympathetic as flight or fight and the parasympathetic as the status quo. And parasympathetic and sympathetic nerves work together to make everything in our body work as a status quo, but can be disrupted, as you can see. The sympathetic system goes to the bladder neck, which is very important. And then the somatic nerves are things that we have control over. So you can see how complex this is how many nerves are coming out to come into this one nerve here, how many areas of the sacral spine are the nerves coming out here and here. So it really is quite complex. And so people who have neurogenic bladders may have some function, may have no function. There certainly is a variety of ways for the person with neurogenic bladder to present with their urine symptoms. So two goals when we think of neurogenic bladder, one is to protect the kidney and the other is social continence. Those are the two main goals that we have. And the urologist is going to work very hard to be sure that they are protecting the kidney. And the urologist is, I know you have a lot of specialists who need to take care of your child or you throughout your life, but I will say that the urologist is one of the most important subspecialists who need to get to know yourself or your child and to follow you throughout life. I'd like to do a little diagrammatic thing here and really look at it in the simple way that I look at it, because I'm not a urologist. I don't do all those fancy urodynamic studies to figure out how the bladder works. But here is the bladder. Here's the urethra where we urinate from. Here are the kidneys up here that make the urine, and the urine goes down into the bladder and is held in the bladder. I usually think of the bladder as kind of a balloon or a ball or something that holds the urine. And sometimes in a neurogenic bladder, it's very loose and the urine just leaks out the urethra and you have urine leaking into the diaper on a very frequent basis. Sometimes the bladder is very high, it's more tense and there's high pressure. And sometimes the pressure is so much that it makes the urine go back up. And we call that vesicoureteral reflux. And so it goes back up. And then sometimes it goes back up further. And sometimes after a chronic period of doing this, it really causes a problem you can see on the right where the ureter is really wide and tortuous, and you get the hydronephrosis that you're always hearing about with the renal ultrasounds. And so this is what sets up damage to the kidney and development of chronic kidney disease. The statistics I have seen about people with spina bifida and neurogenic bladder who develop chronic kidney disease over the lifetime is 25 to 50%. I know that's a huge variety, but it's a lot. So it is important to really do good bladder health to prevent chronic kidney disease. One of the ways to help prevent that is to do screening. So most of you know that we need to do screening on a yearly or every other year basis. The National Spina Bifida Patient Registry that has, I think it's about 26 or 27 clinics across the country now, looked at the data that has been submitted from patients. Thank you very much if you are a participant in it. They found that 62% are screened at least every 2 years. And part of me says, only 62%? Oh my gosh, we really want that to be close to we want it to be close to 100%. But the screening that needs to be done is a renal ultrasound, and you can see at the top a child getting a renal ultrasound. The kidneys are close to the back, and the renal ultrasound, you can see the kidneys from both the front and the back. But that needs to be done on a yearly, if not every other year basis For the most part, the children we see, it's done on a yearly basis. The other thing that tells us something about the kidney function is the creatinine. So if you go to the clinic on a yearly basis, they generally draw blood, and what they're checking is maybe for anemia and some other things, but one of the most important things we're checking is the creatinine to be sure that that's normal for age. And as that creeps up, if you're not already seeing the nephrologist, the kidney doctor, we're going to get you right to the kidney doctor to be able to evaluate to see if you're developing chronic kidney disease. So what are the factors? Who got checked more? And it really was in a clinic setting. It depended upon the clinic. Every clinic varies. Younger age, we're much better at a younger age of getting this screening done. And then we're, for some reason, much better on those who non-ambulatory status. So those who are wheelchair ambulators and those who have had prior bladder augmentation, which is a special surgery I'll talk about in just a little bit. But people who have bladder augmentation probably are followed by the urologist a little more closely and a little more likely to get this screening. But please know that this is important on an every 1 to 2 year basis, even as you're an adult. So if you haven't been to the urologist in a while or haven't had the screening, this is my recommendation to give them a call on Monday to make your appointment. So one of the things that we find very important in our clinic is that one of our goals is to be drive by 5. Now, I appreciate that this doesn't always work, but we would like for the social emotional health of the children, for the kids to go to kindergarten and not have to worry about wet diapers, poopy diapers, and getting made fun of by other kids. So we like to work towards drive by 5. Doesn't always work. There's a million things that get in the way. There's other surgeries, there's orthopedic issues, there's lots of issues that get in the way. But this is our goal, is that the kids are somewhat dry by 5 so that going to school is a little more positive, is hopefully a lot more positive for their social emotional health. So when we talk about urinary continence, what do we mean by that? For the most part, what we mean is that the child or the adult is cathing, or they're urinating in the toilet on a timed elimination plan, which we'll talk about in just a minute, but that they're relatively dry. We used to think that with the National Spina Bifida Patient Registry, we looked at urinary continence as pretty totally dry and only having urine accidents maybe less than once a month or less than once every couple of weeks, except when you're sleeping. And then the studies, we found out a few things. We found out, and I realized I'm not in the right order here on this, and I apologize. So, but from the National Spina Bifida Patient Registry, Dr. Chu et al. With the Journal of Urology, found with the adults that 77% performed clean intermittent catheterization, that's our CIC. And for continence, the daytime dryness, 45% of adults with the myelomeningocele or the open defect were continent, and 63% in adults with non-myelomeningocele or the closed defect. Bladder continence is associated with employment. So for adults, those who are employed are more likely to be continent of bladder, or perhaps it's the other way around. We really don't know. It's an association and not a cause. But this is what Dr. Szymanski and his group found in a study of asking adults, and some of the adults on this webinar might have participated in giving information to the Spina Bifida Association and the and gathering data. But what they found is that quantity, not frequency, predicts bother with urinary incontinence and its impact on quality of life in adults with spina bifida. So it's not so much that they have no urinary wetting in a month, but that they really just have a small amount as opposed to a large amount. So quantity really made a big difference for urinary continence and not the frequency. And this was really an important part, important thing that the National Spina Bifida Patient Registry really needed to look at. And they actually have since changed the questions about urinary continence. And for those of you who participate in the National Spina Bifida Patient Registry, you might have noticed the last time that you answered questions that the urinary continence questions have changed to really look at quantity and not frequency. So thanks to the adults for participating in the questionnaires and really giving us information about what's important for people with spina bifida. So clean intermittent catheterization, I know we've already said the importance is that we need to protect the kidney, and it's for social continence. So one of the things that the urologist might say about the baby is they might say, you're fine. The baby's urinating well, there's low pressures, the urine leaks out fine into the diaper, we're not a problem. But sometimes the urologist is going to say, the pressures are too high, there's urine going back up towards the kidney, and you must catheterize to protect the kidney. So that's important to follow, to know that sometimes the urologist is saying you must cath to protect the kidney, and then sometimes they're talking about cathing for social continence. Sometimes every specialist says things differently, and I can only tell you that you are the experts because you see so many subspecialists that we all say things just a little differently. And occasionally the urologist is going to say everything looks normal. I had this happen with a patient, with a mom of a child who was 4, and right at that time, are we potty training? Is she going to urinate in the toilet? Do we need to start cathing? What's going on? And really what the urologist was saying is everything is normal for a neurogenic bladder. So be careful when the urologist says everything looks normal, please ask them, what does that mean? How are we going? How are we proceeding? Not everybody's going to say it that way, but sometimes that's the way it's going to come across. And what the urologist really was saying in that situation is that the kidney's protected, we're not having problems with urinary tract infections, and she's urinating fine. So beware of that as a caution. I'm going to skip on to self-CIC. We always, when we recommend that kids start cathing, we recommend that the parents do it, of course, and that the parents learn how to do it. In our clinic, we have the family come in for a class, and our class includes the individual, one person at a time, and it is with the urology nurse and the child life specialist. And the child life specialist has dolls to be able to show how it works, and normalizes the procedure as much as possible and reassures both the child and the parent. And then at some point, we want the child to learn how to do the clean intermittent catheterization on their own. And there's much debate, I think, among spina bifida specialists and professionals to recommend in terms of their recommendation or when is the best time to start CIC. My attitude is that you're going to encourage a child to be able to start CIC much better at the ages of 5 to 9 than you are at 12 to 13. And for those of you who have those preteens, it's hard to get them to do anything different than they've already done. Dr. Schechter did a study a number of years ago now that really showed that those who were really cathing on a long-term basis, cathing themselves, started at a younger age. But I have seen some stuff lately that do show that some people will start cathing themselves at a later time. So one of the things you want to do is to figure out, is your child ready to start cathing themselves? Now, within this, it doesn't mean that you're going to send them into the bathroom by themselves without supervision. I am not saying that at all, and I always have to stress that generally the kids at these ages still need supervision. But you have to think, are they developmentally ready? Can they focus? Can they follow directions? Can they balance? Can they balance on the toilet to be able to cath themselves? It takes 2 hands to be able to do that, so it's going to be hard to use one hand to balance if that's an issue. Do they have the dexterity or the fine motor control to be able to handle the catheter? Do they have access to the urethra? Sometimes it's a little harder for girls than for boys, But it can be challenging, especially if you have balance issues. If someone is heavy, sometimes it's a little harder to have access to the urethra. Many parents will say, well, she can't see it, so she won't be able to cath. And the girls, although you may learn with using a mirror so she can see what she's doing, the girls are going to cath themselves by feel. And then the other thing is, if you don't feel like your child is ready, which is fine, you can start having them participate in the process, opening the package, washing their hands, opening the package, getting the gel, whatever it is they need to do, as long as they're gradually participating more and more in the process. What I'd like to do now, I know there's already a lot of stuff in the chat, so I'm going to stop to take a look, but I would like folks to let me know what age their child started cathing themselves, or for the adults, what age did you start cathing yourself? And just put in the cath, the age number.
I just had Christy mention that her mom taught her how to cath between ages 4 and 5 because it made her feel more independent at school.
Excellent. Independence is very important. It can really help with self-confidence.
We have 2 saying 6 years old, 1 saying 4-ish. Anyone else? What age did you start cathing, or what age have you started your kids cathing?
Thanks so much for sharing. It's nice to see what age has worked for you, 9 or 10. So there's someone sharing that your son is 15, that socially soon that's going to be important. And another saying at age 5 through the appendical vesicostomy. Excellent. And having a vesicostomy until 12. We'll talk about vesicostomies in just a little bit, but that's it's challenging because then once you get the augmentation, as the vesicostomy is closed, you must cath. So the urologist has to be pretty confident, and the family has to be confident in it. But I like the idea of the independence, is that the kids then feel more confident. But as the psychologist before me pointed out, that sometimes it's just gets old and tiring and you just don't want to do it. So that was a good segue into talking about cathing. Oh, now I'm trying to get the chat box out of the way. I apologize. How do I get the chat box out of the way? Oh, here it is.
Did it pop up as a separate? Oh, you
Yeah,
got it.
I had something else over it. Boy, can you tell my age? I'm not that good at all this tech stuff.
No, not at all. You're doing great. We did have one person ask what is a vesicostomy, and I know you said you're going to mention that in a little.
We're going to get to that. So I'll try to hurry up though. Incontinence products, many people have pull-ups, they have briefs, and they have urinary pads. This is just a personal choice. I have lots of teenagers who wear their pull-ups and they're continent of both stool and urine. And I ask, why are you wearing a pull-up? And they're like, just because. And they just feel better. And I'm like, whatever they feel good with is good with me. So I find that a lot with teenagers, is that they're just worried and so they want it. Briefs work. Urinary pads for those who do have just a little bit of urinary leakage but are cathing and have pretty good social continence and just need something to catch. Urinary pads are good. I recently had a discussion with one of our families, and I think her son is 10 or 12 and doing well. When he walks, he wears KAFOs and he wears pull-ups. And apparently for him at school to be able to cath, they've got to like get everything off, and it is a very big deal. So of course he's missing a lot of class. And it was recommended to me by an adult with spina bifida that you can use the pull-ups, but just tear the side and let the front part of the pull-up fold down, do the catheter through the urethra for the boys, and then push it back up. And then you pull your underwear or your pants up and it holds the pull-ups in place, even though you've torn the side. I thought, I've been doing this for 14 years and I really like that idea. So that way they didn't have to take the KAFOs off and, and have all of that bulky stuff and make the whole process of cathing a huge deal that takes 10 or 15 minutes. But there's lots of choices for incontinence products. I do want to talk about timed elimination with urine. We do have some patients who are able to void in the toilet, but have to do it on a pretty regular basis and do have leaking at times. I'm thinking of one patient I saw recently who I've seen since he was young, and he's now 15, and he continues to void in the toilet, but he's got to get there quickly. He's got to go every 2 hours, and oxybutynin helps. Oxybutynin can help the bladder hold the urine. So some kids really will do fine without cathing, and some adults, as long as they're doing timed elimination. So what you need to do is either with the clock, plan every 2 hours that they go to the bathroom, or with their cell phone, not for the younger kids having cell phones. I'm not suggesting that by any means, but having some type of alarm, maybe it's on a watch, maybe it's, if they are older, on a cell phone that reminds them to go to the bathroom, and they can do timed elimination. The teenager I saw recently was very good. I said, well, he goes, he has some leakage sometimes. I said, when does that occur? And he said, if I haven't taken my oxybutynin for a couple of days. And he'd already figured out what the problem was, and he knew how to fix it. And there really wasn't anything else to offer because he'd already done the problem solving. So he's been doing well with that. And so there are some who do well with timed elimination. The vast majority do need to use clean intermittent catheterization for the social continence. And of course, as we said, some need to do it to protect the kidneys. I will say, I don't think I've mentioned the percent, but for those with myelomeningocele, the percent who have neurogenic bowel and bladder is I think about 90 to 95%. It's a very large percentage. I see some more questions.
Yes, I was just about to interrupt you. We had someone mention my 15-year-old boy is in a wheelchair. He knows he doesn't want the surgery to cath through the belly button. With relearning with KAFOs, we struggle with how and when. So do you have recommendations for
how and when to cath? Is that the question?
Is that your question? It looks like Trina, is that your name? Yes, that's the question.
Oh, okay, gotcha. Yeah, so I think one of the things you can do is start cathing twice a day. You can cath in the morning when he has the ability to sit on the toilet, or if he's not able to sit on the toilet to do it, to lay down and do it. And so you can do it in the morning and you can do it at night, or you can do it maybe 3 times a day, in the morning, after school, and at night. So you gradually figure out what are the most advantageous ways to do it. What doesn't take too long? What help does he need? Meeting with the occupational therapist can be tremendously helpful. Our occupational therapist is always helpful about what does the patient need to help support to be able to do self-cathing. So I would think about those things. If you're ready to start, maybe try twice a day so that he gets some comfort level, he gets some confidence in it, but also meet with the occupational therapist if you're having trouble figuring out what are the logistics of having him cath himself. Does that help? I hope.
Awesome. I had another an adult questioning if they have frequent incontinence and using incontinence products, but it's pretty much all day wetness. They used to have a leg bag that exploded, but they don't want surgery. What are some of your recommendations?
That's a good question. You can ask the urologist for the leg bag, so that would be another way to deal with that. Oxybutynin is helpful. I defer to the urologist for the oxybutynin, so that can be helpful for the bladder to hold the urine so you can get from catheter, from catheter to catheter. I think those are the main things. Am I answering the question? They do have condom catheters as well for guys.
Okay. Those seem like good recommendations. Yeah, that was an answer to those questions.
Okay.
Another question, what's your opinion on Poise Impressa for incontinence?
On what?
Poise Impressa for incontinence? I think Poise is a brand.
I don't know the brand. I'm not familiar. I apologize.
Would you like to expand on that question? It looks like Morrigan. They might be typing. I know Poise is a brand of I think diapers and pads as well.
Okay.
So, but if we end up getting an expansion on the question, I will let you know.
Okay. All right.
And so far, I think that's all we had in the chat.
Okay. The one of the things we find is the vast majority of patients I see are on Medicaid, and they are able on the Arizona system to get incontinence products, but there's no choice on brand, so it doesn't tend to be the better brands. And that's always a choice that families have to make, because there's always so many out-of-pocket costs that are in additional anyway when there's any kind of chronic healthcare need. I know. Go ahead.
Sorry, there is another question if you are ready for it.
Go for it.
What are your thoughts on the Pure Wick system?
I do not know the Pure Wick system. I'm glad I came today, because now I'm learning.
Christy, would you care to expand on the Pure Wick system? I can also type it into Google real quick, because I don't know what it is either.
Right. I just realized that I'm taking up more time than I should on the urine and do want to get to the bowel.
Okay, absolutely. Feel free to move on, and we can come back to it in a little bit.
I apologize, everyone. So in school, what's really important is that your child has a 504 plan or an IEP, so that you can work out the logistics of going to the nurse for the cathing. And I know the psychologist already talked about adjusting, so they're missing as little bit of class as possible, and just try to think out of the box about when's a good time for for the kids to go to the nurse or to go to whichever bathroom that you figured out is appropriate for them. So I probably don't need to tell the people on this webinar, but be your child's advocate, and you can always be nice, but sometimes you need to be a little pushy. I am not a parent of a child with spina bifida, but I am a parent of a child, an adult now, who had an IEP throughout school. So I remember those challenges, and remembered that I needed support from other families and learning about how that all works. Surgeries, I'll try to go over these briefly. A vesicostomy is when there's too much pressure in the bladder. It's causing a problem for the kidneys, and the urologist takes that bladder and makes an opening on the lower part of the abdomen, so the urine just continuously leaks. And what a lot of people need to do is to put a pad or a folded diaper over that area and then put a pull-up over that. So it often takes more incontinence help with that. Then at some point, when the family is ready, when the child is ready, then a bladder augmentation is done. And that means that they take a piece of the small intestine, the ileum, and they make the bladder bigger. So the picture over here on the top, you can see that this round piece is the piece from the intestine, and then the rest of the bladder is the bladder. So what happens is this really helps protect the kidney, but it does a couple things. It makes the bladder stiff. And then the second thing it does is inside the bladder, the lining of the intestine is different than the lining of the bladder. And the lining of the intestine causes mucus. So then you get a lot of mucus in the urine, in the bladder, that needs to be irrigated. So in addition to cathing, which is required at this point, you also need to put a catheter in and push water in, take it out. Push clean water in, take it out. So you need to irrigate, and the urologist will give you those instructions. The biggest issue with the bladder augmentation is that there's a risk of bladder rupture, which is a very serious medical issue, and there's a risk of bladder stones that can cause a lot of urinary tract infections. I think one of the most exciting things that's happened over the last couple of decades is the Mitrofanoff, and that's where the urologist takes the appendix and makes a channel from the bladder to the belly. And then that allows the child or the adult to catheterize themselves through the belly, as you can see in the picture on the right. This is extremely helpful for those individuals who are wheelchair ambulators and need access without having to get out and to do all those other things we had previously talked about. And then sometimes, despite all the cathing in the world, the urine just leaks out too quickly, that the urologist will do something called a bladder sling. So the urologists have lots of tricks up their sleeves to do, and you can always ask them about that. I know, and I often tell parents that I understand, and the teenagers that I see, that surgery is a 4-letter word. So anytime I recommend something that is a surgery, I think sometimes they stop listening, which I appreciate when you've had a bunch of surgeries that you've just had enough. So think about these and, ask the urologist a bunch of questions, talk to other family members or adults who have had some of these to find out what are the issues and what's the benefit, what are the challenges. And then probably the most important thing is to understand that sometimes you may have a urinary tract infection, and sometimes you just have bacteriuria, or you have bacteria in the urine. Because with a neurogenic bladder, you cath on a regular basis, that means that there are bacteria in the urine normally. So if you're not sick and don't have other symptoms of a urinary tract infection, what I find is that when you go to the emergency department or your primary care provider, and I was a primary care provider at one time and I did make this mistake, is that we would just check on a routine basis and then find bacteria. When do you need to treat? The urologist always asks, is that urinary tract infection with a fever or without a fever? So talk to your urologist more about that. And certainly some people do have real recurrent urinary tract infections and need antibiotics on a daily basis to prevent, and that's where the urologist can be very helpful. In the interest of time, one more thing. Hey, this really good survey was done of people who use catheters, those with spina bifida and other medical issues, to find out which health plans are covering catheters. And really what they found, the numbers you see are the covers where none of the catheters. So if you look at the first one, the straight uncoded, the public government doesn't cover 6%. For the straight coded, it doesn't cover 4%. And then when you go across and you look at the commercial plans, you see that United Healthcare is a big problem. And so what the organization who was looking at this was trying to gather is the information so they could go to United Healthcare and say, hey, look what's going on. People need these catheters on a regular basis and they should be covered by insurance. So hopefully this is going to make an impact coming up. I'm going to skip over this. The management of myelomeningeal study is the intrauterine repair and the studies that they've done. What I do want to say, though, is that for the moms too, for those who had in utero repair compared to those who had postnatal repair, they are finding that there's no difference in the urodynamics. but there is better outcome in the bladder control. I couldn't tell you how much better, I couldn't tell you what percent, but there is some improvement in bladder control. So that was exciting. And I'm going to pass over this because it doesn't have anything about urine or bowel. So let me talk about the bowel, which is what I spent a lot of time on in the clinic. And here again on the left, just like with the bladder, is your spine. Here's T10, T11, T12, L1, L2, and then of course some of the very major innervation to the bowel, and especially the rectum and the sphincter that we allow holding urine, holding stool or getting it out, is controlled by sacral nerves. So that's why the vast majority of those with myelomeningocele have neurogenic bowel and bladder. But you can see again how complex the innervation is. 2 goals for stool: treat and prevent constipation, and again, social continence. Neurogenic bowel dysfunction, it affects a lot of things. It affects urinary incontinence. And I think most people say, wait, that's a different system. But it's really intertwined. And the first thing that the urologist is going to say when you have a lot of urinary tract infections is, are you constipated? And whether you have neurogenic bowel or bladder, neurogenic bowel or not, that's what they're going to ask. Urinary tract infections, it can affect shunt malfunction. It affects skin breakdown. If you think about the large stools coming out of the rectum, especially in the little babies, you can really see that. Hemorrhoids, anal fissures, loss of work and loss of social and work opportunities, and decreased quality of life. So this is important. What can you do? You can make some dietary adjustments for those with little ones. You can do breastfeeding. It's easier to digest, offers better restoration of the microbiome after surgery. What we mean by that is that breastfeeding is really good for the bacteria that are in our gut. There's a lot of study now about what things are good, what things aren't good for the microbiome, and what's the benefit. Eating fiber, drinking a lot of fluids can be helpful. And exercise. These are some of my favorite pictures. On the left is one of the walk and roll-a-thons in Arizona. And you can see our physical therapist is leading some activity and dance and really getting some motion. And on the right, you can see one of our little patients on a scoot. Scoot is like Zip-Zac or the Bumble. There's another one I know coming out. I just heard about the other day, but our Arizona chapter of the Spina Bifida Association of Arizona has a rental program with the Scoot. And it just allows those kids who can't crawl around and get into things and play with their friends to be able to move around, and is very good. But you can see it helps with getting some exercise. Medications, I'm not going to spend a lot of time because I'm talking too much. Miralax can be very helpful. The problem with Miralax for people with spina bifida is that it just causes runny, uncontrollable stools. You guys already know that. I learned that from parents in the first few years that I was working in a spina bifida clinic. What I found for some is that it's helpful for the babies and the little ones if you really take a small amount, like just a teaspoon. Literally get your teaspoon out of the kitchen, measure a teaspoon or maybe 2, play with it, and see if you can find some regularity from day to day. Pediatric liquid glycerin suppositories are another of my favorite. They really look like a little enema, but they are called suppositories. It's just a little ball of fluid that you can push in, take it out, hold the buttocks together, and then that can really make a difference. It says it's for 2 to 5 year olds, and I certainly use it at 1 and above. Senna is a laxative that is a stimulant laxative that can be helpful. Lactulose is more an osmotic, like the Miralax, just causing runny stool, but not as bad as the Miralax. And that's a prescription, and there's lots of others. So seeing your clinician and asking what kind of medication aids can be helpful. So then you get to the point about potty training. What does it mean for kids with spina bifida? One of the things that I'm always impressed with, or always feel like I need to tell parents is feel free to potty train, get that potty chair, introduce them to the potty. I think all of that is good, but please do not give them grief because they probably don't know before or are not going to have control. So don't give them grief as you're doing potty training. What I find is the education of the extended family is more challenging, is oftentimes I'm seeing the child with mom or with dad or with both, but I'm not seeing them with grandma or aunt or someone who is really there taking care of the kids while mom is at work or dad is at work. So I really want to put out a plug. I know with COVID, you could only have one person at a time or two people, but it's really important for extended family members to learn about neurogenic bowel and bladder and what that means. Now, what does bowel continence mean? We talked about urinary continence, and it's the quantity is more an issue. With bowel continence, it's really you're continent or you're not, and any amount of bowel leakage is challenging and difficult, especially when you're working. I saw the adults yesterday, some young adults, one of whom. A couple of them actually were working, but the one of them who was working said, I can't do anything during the week because I'm working and I can't have an accident because I have to be working. And so she does a bowel clean out on the weekend. So bowel continence really means that there's no bowel accidents. So what did the National Spina Bifida Patient Registry did a good study to look at the data that was collected, and they found that 58% of adults with spina bifida and a neurogenic bowel had bowel continence. 55% of adults with the myelomeningocele and 75% of adults with non-myelomeningocele. It was significantly associated with employment. Again, doesn't mean that employment made you bowel continent or that bowel continence got you a job. It just means that those who were employed were more likely to have very good bowel continence. Those on private insurance, those with the closed defect, not the myelomeningocele, but more the lipomeningocele, and then educational attainment was also associated with it. Now, what are the options for it? One of the biggest ones is digital disimpaction. And when I first started in 07 or 08, and I spoke to one of the leaders of one of the health plans and said, we need coverage for all this other stuff. They were like, you just do digital disimpaction. And I'm like, yeah, that's the old style. Now, some people still do, and that does a good job. And if that works for you and keeps you from being constipated and you have good continence, then that's great. Timed elimination is another one. You can sit on the toilet 15-30 minutes after eating, get in a good position. For the kids, get a stool to put their feet on so that their knees are bent. And another thing you can do is give medication. Maybe you give Senna and then 8 hours later they sit on the toilet, or you give a suppository and a little bit later, I know I'm talking too much, sorry. The transanal irrigation is very common. The cone enema and the Parastine are good. Some of you adults may remember that Kimberly Clark Foley that is no longer made. And then there's the antegrade continence enemas. Sorry, Bree, go ahead. What are the questions? Sorry.
That's okay. We do just have a lot of questions. So I was wondering if you wanted to, do you want to finish talking for the next couple of minutes and then we answer questions, or you want to address some of them now?
You know, let me go ahead and talk for a couple of minutes and then I'll stop. So I can answer. I apologize. Again,
No, don't apologize. Sounds good.
All right, so cecostomy, for those surgeries, the tube, the mini ACE and the Chait tube, nice and simple surgeries. That's what I try to explain to everybody. The Chait tube needs to be changed once a year in interventional radiology, which the teenagers I see don't tend to like that. Many of the teenagers I see now with the mini ACE are much happier. The cone enema through the rectum, and then the Parastine through the rectum. And you can look up the Parastine. This is pricey. This is cheap. This is easier to do on yourself. This is harder to do on yourself. There's lots of choices there and lots of things to talk to your clinician about. There's also a surgery where they take the appendix or a piece of the ileum and make a channel to the belly so that you can do that clean out. There's much variety. You need to talk to your clinician about how to make the flushes for those. They can be very helpful, and that's a vast majority of what we do is talk about the flush solutions, what makes it efficient. I don't want the kids sitting there for 2 hours. We want skin protection, especially since they are going to be prone to skin sores. We don't want them sitting on a toilet for an extended period of time. So there's lots of solutions and ways to adjust. I do want to put a plug in, at least for those in Arizona, is that there is a Camp Patrick that is just for kids and teenagers with spina bifida. It's about a 5 to 6 days, and it's up in the mountains outside of Payson because we all want to get cool in June, at least when we live in Phoenix. And what they do there is 3 to 5 in the afternoon is bowel time. So everybody just stops doing, and you go back to your cabins, and all the counselors and the nursing staff figure out what the routine is, for make sure that they can get all the kids through their bowel management so they can have the fun of camp at night. Antegrade continence animas are a newer thing in the last couple of decades, so you can see that a lot more adolescents have it than adults. The thing I would caution about is with the antegrade continence enemas is the kids I've had who really, really, really don't like it and don't do well with it tend to be on the autism spectrum, so have sensory issues. Not that I've had a lot, but I've had a few, maybe a handful, who've had it taken out, and most of it is because of their sensory issues, and it's a little more of a challenge. So just think about that if that's part of the issues, you know what I mean, if that's part of your life. All right, so here is, I'm finally to the end. Sorry, Bree, thank you very much. This is our spina bifida coordinator who retired a couple years ago, Mary, and this is what you need to do. You need to speak to your clinician, whether it's the RN coordinator, the nurse practitioner, the doc, whoever it is. Please use them at the clinic and talk to other parents and talk to your clinician to learn what's going to work best for you.
Yes, thank you so much. That was so informative, and you definitely covered a lot in such a short period of time, so I appreciate that. We have a few discussions going on in the chat, and we'll take the next few minutes to just kind of go over that. Christy mentioned, and this is a question for everybody, not just for Dr. Murphy, so if you have experience, please share it in the chat. She's just curious about any other females that have a prolapsed uterus and how it affects cathing. She said that's her current situation, and it's been getting more difficult to cath as the prolapse gets worse. But the concern from her gynecologist is if doing a hysterectomy might cause the bladder to prolapse. So I don't know if you have experience with that or recommendations for that, or if anyone else does, please add your input and insight into the chat.
I have no experience. I'm a pediatrician, so I apologize. That sounds like a tough one. So good luck. Hopefully someone in the chat will have some feedback.
Mm-hmm. And then we had some more information offered on the Poise Impressa that was it's explained as a bladder support device, kind of like a tampon. It can be inserted and used for up to 12 hours for urinary incontinence, and then you have to remove it after 12 hours. So is that something that maybe you've heard of a similar device, and do you have experience with that? Recommend it or not recommend it?
I have no experience with it, and that might be because I'm a pediatrician. I don't mean to keep using that as my excuse, but no, I don't. But I've written them down. I'm going to check it out and find out what the urologists say about it.
Yeah, awesome. And then we had, if you're adding fiber to Metamucil or through Metamucil, how often do you recommend taking it? This would be for a young adult. Can there be accidents if you use Metamucil? And do you find the Peristeen system is more helpful versus using a cone enema system, which I think you touched briefly on?
Yeah, I think in terms of the cone and the Paristine, I think they both work fine. It's what works, what's covered by your insurance, number one. And number two, what are you able to do independently? So the problem for some of the bowel management things is it's harder to do those independently than it is the cathing. So it tends to take a little longer to get to the independence, but both of them really are doing the same thing. One of the things I found with the Paristine that's a problem is that the balloon may not be big enough to hold in somebody's rectum. It depends upon the individual. So you kind of have to try it. And if that doesn't hold without you holding it, it's going to be problematic. The cone, of course, you have to hold. So it just depends upon your situation and what's going to work in that respect. And the first part of the question, I apologize.
Yeah, it was about Metamucil. How often do you recommend for young adults taking it, and can there be accidents when using Metamucil?
No, there's always a risk for accidents, and one of the things that I tell all families and all individuals is some of this is trial and error, and to figure out what works for you. And if you're already constipated, you're probably not going to get accidents going on the Metamucil. If you clean out and then start the Metamucil, you might have accidents until you get into a good routine. The issue really is a good routine. And I think you're fine to use the Metamucil on a daily basis. And if that works for you after you've tried it for a couple of weeks, then I think that's great. As long as you're having good stool output. I often ask the teens and young adults I see is how much is your stool output? How frequently are you going? And is it a good amount? Some of the gastroenterologists will probably show you something called a Bristol chart that shows you what the stool looks like, and they want you to say which one of those is the stool. So meeting with your clinician can be helpful to see if you're having good stool output is important in addition to the stool continence. So try the Metamucil and good luck with it.
Yeah, and on top of that, there have been a couple of recommendations in the chat for the Metamucil wafers that they work pretty well.
Oh.
And
Do they taste
then,
good?
yeah, that's a good question. Do they taste good? And then Lindsay also made a good comment that much of the bowel management is trial and error, and I'm sure you would agree with that.
Yes. Yes, I always encourage, one of the things that I see is that we prescribe a cone and then we say, when you get it, make an appointment, come in so we can get the teaching. And I've had many families later say, well, we tried the cone once. Please don't just try something once. You really have to do it on a regular basis. You've got to use it for a few weeks before you've said, this isn't for me, because there's so many things to figure out in terms of the solution and the timing and how long and positioning. And yeah, you got to stick with something for a little bit before you say, forget it.
We are getting feedback on the taste of the Metamucil wafers. They're not terrible, but maybe enhanced with peanut butter, Shamika said. And for those who are following the PureWick conversation, we've learned that it is an external catheter, but you can't be mobile with it. So it's not a great, like Tara said, it's not a good social cathing option. But it is effective for what it's intended to do, which is to be an external, non-invasive catheter. So that's some of the feedback on that. Also, I did mention in the chat, not sure if everyone saw it, it's not covered by insurance at the moment. So that's always something to consider as well.
Yeah, insurance coverage is problematic for the Paristine as well, at least in our area. That's it's been a big issue, and it's been, the last 5 years of trying hard to get it covered. So it's improving, but still challenging.
Yeah, that was a great resource, the chart that you shared about the insurance coverage on each of the catheters. I thought that was very interesting. Okay, so we are rounding this chat up. The only thing that follows this before our breakout groups is a break. So if you do have any last questions, please feel free to share them. We have the time to to take them and converse about them right now, but if not, I don't see any more coming into the chat, but I really am appreciative for your time, Dr. Murphy, and for all of your knowledge. I think my biggest takeaway from this is that there are a lot of options, and you really have to walk through it with your doctors and with your specialists to figure out what's the best option for you. So thank you once again. And yep, we appreciate your time.
Well, thanks for having me. Oh, thanks for putting all this together. It really is a great educational resource. So thanks.
Yes, no, I'm so grateful for it. And once again, everyone, these resources are going to be available to you after today. And we'll have everything that was discussed in the chat. We'll make sure to be forwarding that to you as well. And we will be able to get you all of those resources. So we're going to head into a brief break. Our planned break